Dr. Kelson, who is senior lecturer on the 13th law.
13th law. I think you all know me. I also have a different picture while we beat you to the punch with that line. So that's also us at graduation. So you guys are great. Yeah. It was on our group chat. So special thanks to these 4 dudes for being chiefs with me. It was, a fantastic 4 years. This is each of them in their native environment. You guys are great. It's a pretty hard law. It's a pretty hard job. Sometimes your work email really fills up quickly. You have a lot of things to answer at the end of the day. Sometimes you get some pages in the middle of the night. Most of your time that's messing with you. So, that's the thing. The good news is you guys now have these 5 people that are
It's Rhythmic's license. I saw that for the first time. It's awesome.
I think it's actually your student ID or something.
Native environment.
So, to I guess get more into the actual talk of this talk, I got to thinking about choosing a subject, what exactly makes county, what makes it a really good place to train, and I think it goes beyond good pathology, great, thankful patient population, and sort of unusual findings sometimes. I think that it's exposure to emergency medicine that can be practiced, if you want, in a truly evidence-based way. It's a little bit different from what I've heard from big practice in the community. So today I'm going to be talking about the 13th law. So for those of you that are familiar with this, if anyone's ever read House of God, this is the delivery of good medical care is to do as much nothing as possible. So obviously, House of God is a work of satire. So this is sort of a sarcastic title, but I think that there's a negative truth in every piece of satire. So to lead into that discussion, this picture of Hippocrates. So historically, for thousands and thousands of years, medicines had very, very little information to work with and to diagnose and treat patients. You essentially had just the history and the physical exam, and that was it. You didn't have any tests to run. You didn't have any diagnostics. There was no imaging. There was no ultrasound. There was no CAT scan. It was just you and the patient. Over the years, we've obviously developed a whole breadth of technology, and I think that that's a good thing. I think it's been good for medicine. But I guess the question that I want to ask in this presentation is: are we now gathering too much information, or are we gathering it in a way that's maybe a little bit less responsible than we could gather and process? So, alternatively phrased, are we running too many tests, and as a result, are we perhaps overdiagnosing or over-treating our patients? That's truly a question. So, I'm going to discuss the use of quote-unquote medically unnecessary tests and overdiagnosis. I'm not going to discuss overtreatment. That's a whole other talk in and of itself. So, in researching this talk, there's a lot of literature on this internal medicine field. There's a really robust conversation going on. And I think that in emergency medicine, there seems to be kind of a dearth of a conversation. I think that it's important for us to talk about this because when we see the patient, it really is a lot of the time that they're entering into the medical system, and we impact their care greatly when they present to the hospital. The tests that we run and the treatments that we initiate oftentimes are carried forward by providers, both inpatient and outpatient. So I sent this survey out. I think I got a pretty good response rate. There were about 90 people that responded, about half of them faculty, about half of them residents. Actually, part of the goal in sending out this survey was Dr. Smith and Dr. Willis had wanted me to find somebody to present the other side of the coin, which is maybe we should be running more tests on our patients and trying to find more definitive diagnoses. So we're actually not going to do that today because these are the results of that survey. So I was essentially unable to find someone that was willing to make that argument, which I think is interesting. So the left is, those are the people in our department that admit to ordering more tests than they deem medically necessary. So that's everybody but 3 people. On the right is all the people that think that too many tests are ordered in general as a field in emergency medicine. So that's 2 people. If anyone wants to come up and talk about why they feel differently afterwards, I would invite you to do so. So this is the results of a national survey, so slightly different but definitely similar. So my point with this is that we're sort of self-aware that we're doing this. We're aware that we're running medically unnecessary tests, and yet we're still doing it. My point is not that we should not run any diagnostic tests on any patients. That would be totally insane. Obviously if somebody comes in and, I just had this case yesterday, but they were, hypoxic and hypotensive and on birth control and just got off a flight for Bermuda, they should probably get worked up for PD. Right? I'm not saying you shouldn't do that. But I think that the point is we know that we're ordering unwarranted tests or something. So what I'm going to go through is kind of how we got here. So first I'll go through the ways in which this is harmful to both patients and to society. I think we should all but then I'll go through the reasons why I think we're doing it, the internal and external pressures we have that lead to us ordering tests that we perhaps don't even think are necessary. Then I'm going to go through some ways that we can potentially fix these reasons. So this is just a goofy cheap complaint. I really just have a few of these to put up there, just to break up the monotony a little bit. So that brings me to part 1, how this is harmful, how what we're doing is harmful to our patients. So I can't really give this talk without bringing up this graph here. Everyone should have seen it at this point or something similar to it. But the point is that the U.S. spends a lot on medical care, more so than other countries, and it's going up. So running diagnostic tests is expensive, and if you're running maybe unwarranted or unnecessary medical tests, it's still expensive. So we're utilizing resources that we maybe don't have and putting them in places that we don't necessarily need them. So these are some raw numbers from an estimate from a few years ago. It's probably gone up from here, but unwarranted tests and their associated administrative and follow-up costs are about 30% of healthcare spending. So that's like $210 billion. It's a lot of money. And this isn't getting better. We are ordering more and more CAT scans, especially since they're becoming more prevalent and available. There was about a 300% increase about a decade ago, according to some estimates. So that's a lot of, if you think about where those resources could be better spent, I would argue perhaps, at least in the pod, getting a little bit better support staff and more PCAs, more nurses, right? That would be really helpful to us. Just to kind of drive that home, I think part of our job as doctors, and specifically as emergency medicine doctors, is that we should be safeguarding these expensive treatments, expensive tests, and do this responsibly. Otherwise, there would be some concern that maybe somebody would take that responsibility away from us. So I would argue that that's the whole reason why we're specially trained in how to order tests and treatments, and that's why we're the only ones that are allowed to do it. Right? So I would argue maybe we're not doing this responsibly, and that's a little bit concerning. It's been argued by some that one of the reasons that we should be hiring MDs, which are more expensive than, say, PAs or NPs, is that we're a little bit more, we order tests in a little bit more resource-sparing way. And I think that that's an important thing to do, otherwise maybe there would be something that could be argued that we should potentially be, our training should be with this. It's not just expensive to society as a whole, this is expensive to even the patient that's sitting in front of you. The cost of an ED visit has increased about 240% in the last 10 years. Depending on the patient, some of our patients I know don't pay for it directly financially because they have Medicaid, but I would argue that potentially they have to spend a lot of time following up, incidental findings and stuff, and that can affect their income and their health insurance. So I would argue there is a cost, even if it's quote-unquote free for the patient. So this is important, right? More Hippocrates, do no harm. I think that there is real harm to a patient anytime you order, especially if you order a test that is unnecessary. 2007 estimate is that almost 30,000 people a year develop cancer specifically from CT radiation in the United States. So that's a lot. I'm sorry?
More than sepsis.
More than sepsis. So everyone should have seen this graph as well. More tests have not necessarily been associated with better outcomes in any patient population. There's been comparisons. Patients that get more tests performed on them, even for the same pathology, tend to actually do worse. They don't tend to do better. This is a graph of essentially the quality of health care that we're providing in the United States compared to the amount that we're spending. So we're spending a lot more than other countries that are providing similar care. This one's life expectancy. There's similar graphs for infant mortality. So this is a more specific example. I mentioned PE earlier. I think that this is an important concept to grasp as well. As technology has progressed, as CTs have gotten better at picking up smaller and smaller findings, and as they've become more available, more CTAs have been ordered, and more smaller and smaller PEs have been diagnosed and picked up. More of these patients have been treated. So the issue with this is that this is the difference in mortality over this course of time. Right, so we're ordering more and more tests as they're becoming more available, and it doesn't actually affect patient outcome. This doesn't even account for any side effects from anticoagulation and follow-up that patients are getting potential iatrogenic harm from incidental finding. Right. So similar data. If you look in the IM literature, I mentioned earlier that there's more of a robust conversation going on there. There's similar data for both breast cancer screening, so that's mammograms, and for prostate screening, so PSAs. This is another example. We discussed this in EBM this year. So this is kind of gets in a little bit to overtreatment. It's also internal medicine, but if you have stable coronary artery disease and somebody decides to do a diagnostic cath and perhaps put a stent in, you do just as well with just medical management. Right, so it could be argued that that's perhaps unnecessary in patients that are not benefiting from this procedure. This is another one just threw in there just for laughs. I guess if it was dark rum, it makes a little bit of sense. So that brings us to incidentals, right? I think that this is really important. Let's say that you have a diagnostic test to run. You want to answer a clinical question, so you take an image, and you want to answer that clinical question. You take that picture, and you expect to find one thing, and then so everyone's had this experience, right? You order a chest X-ray, and then you get a phone call, and it's a radiologist, and they say, "Well, your patient has a lump on the chest X-ray, and they need to get some follow-up tests." So I think that the incidental thing is incredibly. I tried to find a paper quantifying this. I think it's really difficult to quantify because there's so many downstream effects that could be argued or may not be related to, finding that initial lump on the chest X-ray. What do people's sense on whether this is more or less harmful than, say, radiation? People have anything
Incidentals is more or less harmful than the radiation risk?
than radiation or,
Well, I think it's the patient's emotional reaction to these
Right.
tests. In Germany, for a few years, everyone got HIV tested, right? And the suicide rate went up dramatically
Right.
because there were false positives. And patients would get the false positive, would kill themselves before they got the ELISA. So, and when I trained at Mount Sinai, they had the executive exam where, for executives, they would give a perk and they would CAT scan them from head to toe. These CAT scanners would do. And they found so many little ditzels that they were making holes in these people, so many holes, they had to stop after a while and stop biopsying things that they never found anything real, but they made them crazy about doing biopsies. So I think this, don't do a lab test unless you want to deal with the result is a good thing to look at.
Yeah, I thought about this a little bit too with some of these non-indicated fraggles that we do, just because we think has good
wanna start
audit
that.
practice. I think it's good for our training, and I think in the future, by doing this practice, we're going to help patients in the future. But I almost feel weird about finding that this incidental weird thing in their liver or their kidney when the scan was completely not indicated. Humans were talking about their skin, so and that's the windows.
Right.
Right, so I think we should be careful about that kind of stuff too.
So I think this is more harmful. That's my personal feeling.
If you really want to look at evidence, there's really good evidence on PSA for prostate cancer screening
Right.
and mammograms, and there are thousands of patients enrolled in different trials, and you can see how much damage these two tests have been doing.
Right. So, this is one paper that I found. My line here is that there's, sometimes you find a lump and you don't know if it's a dangerous lump or a benign lump.
American stuff goes backwards.
But, so I like this paper because it's on abdominal CTs, which is something that we order regularly. So what these authors did was they looked at all these abdominal CTs that we ordered in the emergency department, and then they looked at how many incidental findings we had. So you can see 700 incidental findings. Radiologist called and said, this patient needs urgent follow-up in about 143 of these. So of the patients that actually got follow-up, about 24 of them were deemed quote-unquote neoplasm. So that's sort of where the paper ends, which I think is unfortunate because we don't know, A, how many of them were actually serious, B, how many got further testing with biopsy, C, how many patients actually benefited from that quote-unquote incidental finding. And the problem is that every step of the way there's a burden to the patient, right? So as Dr. Sinnert said, there's a component of anxiety that can have real health effects down the line. And then as I said earlier, this can really interfere with employment. It's very time-consuming. The patient has to go to the doctor several times. Sometimes it can even, depending on exactly where you're living and what your situation is, it can affect your health insurance, right?
Plus the risk of iatrogenic injury.
After, from biopsy and stuff like that. These are all taken from categories. There's also this phenomenon in radiology literature, where, as more images are ordered, the radiologists are dealing with a bigger imaging burden, and they're able to spend less and less time with each image. So as they do that, they tend to hedge more. So that means finding more and more quote-unquote incidentals or ordering more follow-up tests.
I just want to mention one thing. I think we have to be careful about framing an incidental conversation and comparing it, in our practice, comparing it to screening tests, like PSA or HIV screening. Because in theory, maybe not everyone practices there, we're doing a test looking for a specific thing.
Right.
So the risk aversion there and the window is much different than screening, every person for prostate cancer versus doing a chest X-ray, potentially, hopefully, looking for a pneumonia, pneumothorax, that is a little different. So I think just wanted to put that out there.
Sure. Yeah, I mean, I think that it should definitely be something that you have to weigh how much. I'll get into this a little bit more, but I think weighing how much your patient's going to benefit from the test versus the chance of actually not benefiting.
And there's definitely spectrum.
There's a spectrum of things that I think that So I guess the point with this is that as more follow-up images are ordered because the radiologist is hedging, then that presents them with more images, and that enters into this sort of nasty cycle. They're looking at more images and they have to hedge a little bit. So this is kind of getting into I guess what Dr. Rose just brought up. This really comes down to a numbers game, right? So I think that obviously if you're ordering a test and it's warranted and you have a real clinical question that you want to ask and you want to answer that question, that's an important test to run. However, if it's a unwarranted test that even you don't think is warranted, which we know we're doing, there is real harm. You're statistically unlikely to harm that individual patient, but if we're doing this consistently over many, many patients, over many, many encounters, over many, many years, you're going to hurt somebody. So the cumulative effect of that is potentially disastrous, right? And that's sort of separate from ordering a test that you're ordering for specific diagnostic questions that you have. That's an important test to run. That's a little bit different. I think, so this is the next question, is why we're doing this. We know we're doing it. We're ordering tests that we don't think we necessarily need to order. So there's reasons why we're doing it. We're not in this field to hurt our patients. So I think that, sometimes talking about money seems like a little bit dirty in medicine. Sometimes you use euphemisms to talk about these things. I think fortunately in emergency medicine, we're a little bit insulated from this, but nonetheless, I think it does matter. We're not like orthopedic doctors with a stake in the radiology practice down the street. We're not doing tests for that reason, which unfortunately does happen. However, there are financial incentives that drive some places to order more testing. CMS is attached to some quality protocols that do require you to order tests that you may or may not think are warranted. So I think that in some cases does drive us to order some things that we don't think are unnecessary. So this is more of a technological perspective. So a diagnostic, everyone should be on board here too, but even a diagnostic, quote unquote, true positive doesn't necessarily mean that it clinically correlates with something that's relevant. So to bring up CTA again, with the advent of helical CTAs, we're picking up more and more smaller sub-segmental PEs that may or may not be clinically significant. I showed the chart earlier. Just because we're picking that up doesn't necessarily mean that it needs to be treated. And that's a conversation that's going on here in emergency medicine now. I'm not saying that's true or false, but it's something to think about, right?
It also may already be treated. If you have a PE in the past and you're on anticoagulation and you have new symptoms of chest pain and shortness of breath, I think you probably got a PE, but you're already being treated for it.
Right.
And I've had numerous conversations with medicine units saying they insist that the CTA be ordered. I was like, wow, what are you going to do with the information? Like, well, we have to see if it's bigger. And I was like, why? Like, what's it going to change? You're already being treated. So you're being treated with cameras.
So that brings us to this, right? So I would argue that that's actually a clinical true positive, right? Even if they're symptomatic from a PE that you find on a CAT scan, it doesn't necessarily improve or change their outcome. So it's a related but separate concept.
In mammography, they had to change the name of introductive carcinoma because that's what they were finding on mammograms, and they realized that treating it and not treating it didn't make a difference, so they just changed the name.
Right.
Yeah. It's ridiculous.
What's it called?
Now I'm calling it wrong.
one of the things I want to bring up with diagnostic tests in general is if you're going to introduce a drug to the market, you have to go through a fairly rigorous process of getting it ranked by the FDA, the safety profiles, and the test effectiveness and efficacy of the drug. Diagnostic tests don't necessarily undergo the same rigorous evaluation. So there's not necessarily any long-term follow-up as to whether these tests actually change outcome. So an example of that is running a BNP on a patient. So there's actually a study on that where they looked at patients that had BNP sent with CHF, and then looked at patients that didn't, and they looked at overall diagnosis and clinical outcome, and it didn't actually make a difference. So it's actually it has pretty good test characteristics, right? Sensitive and specific, but at the same time, when you send that, it doesn't necessarily make a difference in the patient's outcome. And this is just sort of another question that I want to ask. I think it's worth thinking about. I don't necessarily think it's correct, but I think that historically emergency medicine has been sort of a field where we all went into this thinking we were going to be treating the board on the left, which is sort of these like sexy gunshot wounds, septic patients, and get to do a lot of intubation. And I think that more and more as the emergency room has become a place that we treat a lot of uninsured patients and patients that are coming because it's convenient, maybe patients that don't even necessarily think that they're having an emergency, which is a good thing. I think that we should be treating those patients. It's a fantastic thing that we do. I think that it's changing the, we initially had this rule out culture, which still exists, where you have to rule out the bad stuff in every single patient that comes through the door. And I just want us to ask and have a conversation as a field as to whether we should still be doing that for every single patient, even if that patient doesn't necessarily think that they're having an emergency problem. Just something to think of. So, I think that, yeah. Anyone remember this?
Yeah.
The whole board. Anyways, I think that there's also this culture of normativity in emergency medicine where, and I think it's in medicine as a whole, just in life, where you tend to practice the way that your colleagues do, and everyone follows these standards of care that sometimes are not necessarily warranted based on the most recent data. And this gets into acceptable miss rates. The next thing. So in emergency medicine, because of the rule out culture that we have, there seems to be this absolute 0% miss rate that we have. And people argue that this is because we live in a litigious society and we're afraid and we don't want to get sued, and so we practice defensive medicine. I would actually argue that that's not totally 100% the case. People that practice in non-litigious societies actually tend to practice the same way that we do. And I think that part of this is just, honestly, it just sucks to miss even a rare diagnosis. Right? It's horrible. Everyone's done it. It feels bad. You feel bad for the patient. If you watch a colleague do it, you feel bad for the physician. But I would argue that we should also have a conversation with ourselves about that. Depending on the diagnosis, obviously we can't be egregious, but if we're harming more patients and running these diagnostic tests to look for a very rare diagnosis, I would argue that we're still harming more patients doing that. So perhaps it's something that we should, discuss, maybe not ruling out every single Z in every single patient. So provider risk aversion. More risk-averse doctors are more susceptible to being less tolerant of higher miss rate. And I think that if you're more risk-averse and you miss something at one point in your career, you're going to be more susceptible to a bias that makes you scared of missing that diagnosis again, even if you never see it again in your career. Right? Is everyone on board with that? So you're then ordering tests that may or may not be necessary and harming those patients from that point forward. Something to think about. So I think that this is all formalized in M&M conference, Right, and this is a knock against our program. I think that we actually do a really good job about this. I think Dr. Schechter is totally on board. But nobody ever gets punished for ordering a test formally amongst all their colleagues in a form. There's a lot of talk about, well, maybe we should have ordered, this extra lab or this extra CAT scan or this extra chest X-ray because of the thing that happened. But there's no discussion about what happens later on the line when the patient is harmed from, cancer several years later, or an unnecessary admission in which they were harmed to the floor. Again, this is harm to many patients over many years, so that's hard to discuss in a formal setting because these cases are hard to find. So the other thing is that we're sort of shifting gears, but we're actually not that good at predicting the benefit and the risk to the patient of diagnostic tests that we do. So this is a review of several papers that looked at this, and they, across the board, found exactly that. We underestimate harms and we overestimate the effectiveness of both our interventions and our diagnostic tests. So I think that we should be helping our patients make these decisions, and I think that we can't really do that if we're not aware of the risks and benefits of each test that we run. So this is a big problem. Because it's hard to balance your clinical judgment in answering a diagnostic test without understanding exactly how much you could potentially harm the patient by ordering a test to answer a clinical question. So this is the amount of inpatient providers and not in the emergency room that considered the potential harms to a patient before ordering a test. That even considered, let alone actually discuss that with the patient. So that's about two-thirds of providers, right? So we all know this is true too, right? We're practicing medicine in a wealthy, industrialized country. Patients expect to go to the doctor, they expect to have things prescribed, they expect to have tests run, they expect answers to feeling like they're feeling. I think that the public tends to believe that earlier diagnosis and treatment tends to be a good thing, which I don't think is necessarily true for every single disease out there. There's also, this gets into over-treatment as well, but there's a medicalization of what's a normal and normal aging and dying process that I think has also led to tests being run on elderly adults that aren't necessarily warranted in that case. So this brings us to part 3, it's sort of what we can do about each of these things that are pressuring us to order tests that we don't think are necessary. So just another one. I still love some of these from my classmates back here, they're not all. I think that's, yeah, they were. I've already used this in a medical lecture. So I think tort reform it would be a good thing. I don't think we should have to totally put asses on the line just to help patients every day. But at the same time, I don't think that that's totally the answer. Like I said earlier, in other countries that are less litigious, the providers exhibit the same behavior. Also, David talked about this last year, but if you order more tests and admit more patients, it doesn't actually decrease your likelihood of being involved in a lawsuit. I think maybe changing the fee-for-service model would potentially do some good here as well, although that's a much more complicated subject that I don't really understand. So I think Derek talked about earlier about incoming, and Matt talked about in his senior lecture, the incoming amount of new diagnostic tests that we're going to have just with point-of-care ultrasound. And I think that this is like a fantastic thing. Right? It's a good test for a lot of things. It decreases the need to radiate patients. But one of the things that I think that we should think about before hand scanning every single patient that comes in is there is actually a potential here for incidental findings that could lead to downstream harm if we're doing this without thinking about it in the patient that we're scanning. On the other hand, I think you know, it's a fantastic test, and if you really know the test characteristics of what you're looking for, I think that this is incredibly powerful and incredibly useful. So this is, talk about here about expanding disease definitions. So a lot of professional societies will expand the definition of what's a treatable disease, just either from pressure from drug companies or just for professional with prestige. So like if you think about JNC decreasing the treatable hypertension guidelines or expanding definitions of autism, that obviously leads to what could be considering placing patients in the bin of having a disease when they don't necessarily have something that's clinically significant. I think we should just think about this moving forward as these societies change guidelines. So I think just to bring up the example of pulmonary embolism again, sort of the theme of this talk is, you know, does every pulmonary embolism totally need to be anticoagulated? I think the answer to that is not clear either way right now, but it is a conversation that we're having. So this is a direct quote from. So I think, you know, we need to educate ourselves about this, especially. You know, we're bad at estimating risks and benefits, and I think that we just need to be aware of these. I think that it's something that we have to discuss as a field of training. And I think ultimately we need to find a way to stop rewarding people for ordering too many tests, culturally and formally. You know, discuss changing a culture of a total of 0% miss rate. And then also, if you know that you're a risk-averse individual, just be aware of that and be aware that you could be introducing bias into your practice. So M&M discussed this already. I think that maybe changing this to look at more systems-based thinking and less on, you know, misdiagnosis, I think would be a positive thing in most cases. This is just so this kind of gets into that concept and the public's perception of what an acceptable miss rate is. Does anyone have an idea what I know I said 0 earlier, but what the actual, there was a survey that went out among physicians that looked at emergent diagnoses, so like meningitis, appendicitis, ectopic pregnancy, and ED providers were actually pretty much on board with this. Does anyone know what the number was for acceptable miss rate? Yeah. So it's 1%. Right? Does anyone know what it is according to patients?
0.
Right. It's essentially 0. They did ask them in the waiting room, by the way, as they were waiting to see.
And administrators.
And right, exactly. But so yeah, these are the numbers. So logarithmic scale different. I think that this is, you know, it's important to provide our patients with good care and give them what they want in some situations, but I think that this is a conversation that we should be having with the public. I think that right now the impression is that it's so infallible that we should be catching literally everything. Although if we were to do that, I would argue we would be doing more harm to patients than we would be providing them service. So this is from the intern year NICU's thing. Does everyone understand this diagram? So on the left axis is interest and age, and you know, initially as you're born, you have this strong desire and, you know, defecating. That decreases you reach your teenage years, and as you get older, it goes up. Inverse is true for sex. You're not really interested as a young child, you become a teenager, you become really interested. My NICU senior hypothesis was that as those two cross, that's when you should be made DNR.
It's a cool word.
They cross too. This is flawed.
So I would argue, you know, the medicalization of the aging and dying process is also leading to more unnecessary tests. It sort of gets into palliative care, so that's all I'll say about it. The ending of the top one there is, I don't like the channel. Right, so this is, I was going to talk a little bit about colonoscopy here and the study that was done in the Journal Medicine world. So they asked patients that had undergone colonoscopy and mammograms, and they presented them with an honest appraisal of the risk and benefits. And they said, you know, if you had known this before you got the test, would you have chosen to do the test again? And 50% of them said, what are you talking about? Why did you do this to me? I would never have done this if you had given me that information before. So I think that the same could be true about the tests that we do in the ED. There were only, we looked at this in the emergency room, and only about 5% of doctors regularly discuss radiation with their patients before ordering a final radiation scan. So that's like an abdominal CT. So we're not doing this. We're just ordering the scans on the patients without really telling them exactly what the benefit or the risk is. I think that this is really an important part of this talk. So we need to be discussing this with our patients more than anything, trying to suss out exactly what they want and what their level of risk is. The other thing I want to point out is that there was a survey that went out to a large number of patients that tried to evaluate exactly what was important to the general population. And surprisingly, or maybe not, it was actually cost. So patients were less likely to be willing to accept a test if it was very expensive compared to if it was not, even if it was maybe didn't have the best test characteristics. So I think that we should be trying to have a, even just a cost conversation with our patients, even though it feels a little bit dirty. And sometimes we don't even really understand it as doctors, which is unfortunate, but I think it's something to think about. And then this is a, so it's actually been proven to decrease test use, right? So if you have a risk-benefit conversation with the patient, they are less likely to be like, yeah, I want to have a CAT scan of my head even though I'm 20 years old and I get these every week. I think this is some patients are harder to talk to than others, right? And there's a tendency to try to just shotgun a bunch of tests off, order some CAT scans, rather than have a conversation with the patient about complex like lifestyle modification. Sir or ma'am, I'm sorry, but doing a CAT scan in your head right now really won't tell me why you've been having headaches since you were whatever age, and you get them every week. So I think that having that conversation with the patient is really important, right? Rather than just trying to get them out of the emergency room by running a bunch of tests. So just sort of in closing, this is helpful, right? Use your decision tools. There's more and more of them being developed, and I think that they do decrease test use. I think it's a good thing. Got a lot of information for the Choosing Wisely campaign. I think everyone should be aware of this now. It's a good organization, provides recommendations as to which things are reasonable to use based on their test characteristics and what's actually going to improve patient outcome. So in conclusion, I think that if we're ordering truly unnecessary tests, it really does cause patient harm. I think that we're doing this from a lot of internal and external pressures that are applied to us. And I think that most importantly, we should just be a little bit upfront with our patients about what we're ordering and what we're doing in our goals with those tests and what we could potentially be doing to harm. So that's it. Just a thanks to Dr. D'Souza, who has been fantastic in making this lecture, Dr. Smith and Dr. Willis for also looking at this. And then big thanks to this guy who, didn't do the whole thing in graduation, but a great teacher for the past 4 years. I'm glad you're sticking around. And then this is a picture of my wife actively putting up with my bullshit. So she hopefully you guys feel great after this week's presentation. Does anyone have any perspectives or any questions or anything they want to share? Yeah. So
first I want to thank you, Kyle, for wearing the formal attire.
My wife's on time.
He's wonderful. Extremely important topic, right? So if we don't do something about this, it's just going to hinder healthcare in the future, particularly in this country. But I just want to caution you that the influence of defensive medicine and financial repercussions and tort reform is not necessarily a bad thing. Because some of those countries that you mentioned have that have just as many excess test screening. They have other reasons for ordering them, and in countries that have universal health care, it might take you 6 to 8 months to see a primary care doctor. So maybe that's the emphasis for those countries. So it's not to say that tort reform wouldn't help in this country, but it's a multifactorial issue, and I think it's a fantastic topic, and I'm glad you spoke about it.
Totally agree.
It's incredibly introspective. I think that we should put more energy into deciding which tests to order and not just randomly stuff. Like, how many PTPTs do we order? That we just don't need any of them. Like, it's just such a waste.
I always ask the anesthesiologist about the PT-PTT. I said, what's the most common cause of bleeding in the general population? You know what it is? It's von Willebrand's disease. And what's the PT-PTT in von Willebrand's disease? Completely normal. So if you didn't ask the patient, you missed it. And yeah, BNPs and dialysis patients. If you do that on my dialysis patient,
or heart failure.
Dr. Barron?
I think we have to define when we say we. We can't do this in a box. How many tests do we order between medicine order and the patient unless we get the PT-PTT?
Right.
I mean, it's got to be done kind of a decision among everyone that we're not going to order the CAT scan because they won't admit them if we don't order the CAT scan. You have to have some agreement between specialists.
Absolutely.
It doesn't work.
Well, your quote was 2/3, and ours is an 86%. That's obvious, right? Then 1/3 of the time they believe it's actually indicated.
Right. I mean, so I think, I totally agree, and I actually think that I wanted to point that out here. I forgot, but every single one of us does this for that exact reason, even if you're trying to practice the best medicine possible. So, I mean, we're not doing it in a vacuum, and that was one of the things that I wanted to get to in this talk, is I think that we should be having internal medicine is having a conversation about this amongst themselves. I think that we should be having more of a conversation about it amongst ourselves, and I think that we should all be talking about it together.
Do you think that's the only reason, Kyle?
No.
Do you think that if we're honest with ourselves, do we only do it because they want it? Do we also do it just because, well, maybe?
Yeah,
It's
totally.
a combination.
It's very multifactorial.
I definitely think the number is smaller, but it definitely exists.
Yeah, the EKGs and chest X-rays break the folks.
But it's easier for us to just say okay rather than to say, well, actually, I don't think that the patient.
a UA for stroke patients.
Oh. Yes.
There's that one patient with UTI.
But I think there's a huge cultural component, and I wonder what many of us will find if we leave this institution. I think it's much worse outside because the incentives, the financial incentives are so much, they're profound. You get paid for doing this stuff. So I think that while it's a problem here and we should be introspective and thoughtful, I think we are so much better than the entire rest of the country, probably.
I'd like to think that.
I do. So that doesn't mean we shouldn't go out and be better, and that doesn't mean we shouldn't legislate, that doesn't mean we shouldn't lobby, because this sucks, and we're gonna just spend ourselves into bankruptcy and foolery. I mean, it's crazy. But I think we are better.
Yeah, I will say that is one of the oft under-touted loves of working here, at least for me, and I'm sure some of the other attendees. Really, I feel like we get very little overhead pressure on how to practice on a majority of things.
We're not wasting money,
so,
no financial.
So it does allow us, it puts us in a good spot to really attack this, because we're not going to be getting outside pressure necessarily from the institution to decrease testing. So I think we have a good opportunity to continue to work on things like this.
There are private practices say you order 5% more CTs than your peers. You're ordering too many, you need to slow it down.
And your patients demand it, and their insurance will pay for it.
Yeah.
And
Yep, and we're losing out on money. We could be billing them for that.
That quote from Kyle from the ED provider, that's much, much more common
Yes.
outside of here.
Yes.
Everyone, I think I know what you're talking about, everyone's shocked by all that, but that's normal practice in a lot of places.
But I will tell you that 85% of the CBCs ordered at UHB are ordered with a diff, which is unnecessary, and that 40% of the patients that you admit to this hospital get the same exact panel of bloods drawn upstairs within 10 hours. It's incredible. Right?
Expensive.
Can we talk about all those CMPs we order instead of just BMPs?
Yeah.
Why do we do that? I feel like it's a culture that's
How about the mag and
I
FOS?
have to say though, sometimes I feel like it ties into how sometimes our patient population doesn't have the best primary care follow-up, and we do use these tests like screening tests. How many times do we find like, abnormal LFTs and a diagnosed liver cancer in the ER?
Not many.
I don't know. Never.
Not many.
What? I feel like more often than we like to think.
It's the same way you order a chest x-ray or like chest pain and then you find that the patient has a mass. You know, I don't know.
It's a little more tempting to practice defensive medicine when you're rushing, when you're running around. And you made the point that we don't want to spend ourselves out of an ability to have adequate nurses and techs. And I think that's, I want to be able to think about it the other way too. Like, if we have more staff, then we'll be able to spend more time thinking and ordering the right tests, and then it's not, and more time documenting, so we feel more comfortable that the litigation is not going to be part of the reason why. I feel more comfortable when I document that I won't be sued, or that my attorney won't be sued for something. Because I'm showing my thought process. But when I'm rushing around and I'm taking urine over to the PLC lab and I'm supposed to be back at the computer documenting, that's difficult. So I think more staff, more ancillary staff would help us.
Yeah, it's interesting. I think that one of the points that Dr. D'Souza brought up when he was looking at this presentation was he does the share. The reason why I think he gets away with what he does is because he has a lot of shared decision making conversations with patients, and with practice, he said, I've gotten very good at this, so it's actually faster for me to go discuss this with the patient and really provide them with their options and the risks and benefits than to go and look at the test. So I think that if we start practicing this way, especially in training, I think that potentially we could practice that way after we're ready to graduate.
Yes, I think I had that experience with him like a shift a couple of nights ago where a patient had fallen like 24 hours ago, young guy like 20, and was like demanding a head CT, and his exam was completely normal, and I kind of went through and had the discussion with him and how it wasn't really indicated, we got the risks like far outweighed benefits of that. And then he just said like, oh, but like, did you give him any hard evidence? He's like, I have like numbers that I go, and he's like, honestly, like, and he said that his method is that he goes through it and says, if you still want to do this, you have to sign a sheet of paper that says you're willing to take on this radiation risk. And he's like, I've never had anyone sign that sheet. And he went and spent 5 extra minutes with the patient that I had, and like gave him the data and said, but if you still are considering this and you want to sign a sheet and say that you're willing to take on this risk, that's totally fine. We'll go that route. And he was like, give me 5 minutes, let me talk to my aunt. She's like on her way here to see what she says. And they decided not to do it. And I was like, I talked to that guy for 30 minutes, clearly he was not doing the right thing, and like didn't get there, and then he went in and did it. It was pretty cool.
I think that's actually one of the bigger barriers for shared decision making is when if you don't feel that you know the statistics well enough to write to share it, to actually teach the patient, you're going to feel less likely to want to do it, right? You want to know that when you're making the shared decision that you truly are giving the right information, the right data. So
along those lines, I was actually going to share this. Just simply forgot. Do people know what the risk of developing a lifetime risk of developing a fatal cancer is from a CAT scan? Are people aware of this?
Is the same all body parts?
Well, so it's different. I mean, obviously, so this is a gross simplification, but the bigger the scan, the more radiation, the higher the risk, and peds have about double the risk as adults. But so for peds, every 500 CAT scans you order, 1 person dies. So that's a lot, right? We order a lot of CAT scans.
I think some of those numbers are exaggerated.
It's based on historical data from
CAT scans that use a lot more radiation, but still, I don't think we really know the answer to that. Maybe hopefully not.
We don't. That's a good point.
Yeah, I agree. It's just an estimate. I don't think we know the real answer.
It's
But
the best
it's
estimate
not
we
0,
have.
is what the answer is.
Yeah, exactly.
Right, that's the number you should know. It's not 0.
Okay, the research, the American College of Radiology, that's the openness criteria. I'm gonna go survey, but that's what the radiology department's doing. It's head CT, inappropriate head CT in the ED. And we're using those criteria, and it lists references and also breaks down by radiation. But also just in case you need some could be patients or talk to your colleagues, that's like a good resource.
What was it?
It's called from the American College of Radiology, it's the Aversion criteria.
Actually, a lot of their stuff is on choosing license. That's where they get it.
Even with EQI project.
Great topic.